Good afternoon. Welcome to our WALS lecture for this afternoon. It's my distinct honor and pleasure to introduce to you Dr. Lois Smith. Could I have the first slide, please, for the introduction? Thank you. Lois is an ophthalmologist and clinician scientist at Children's Hospital and professor of ophthalmology at Harvard Medical School. Lois received her Bachelor of Science degree from the University of British Columbia, located in her hometown, Vancouver, Canada. She received her PhD in chemistry from California Institute of Technology. And here she is, a typical Caltech student in chemistry. And she completed her medical degree at Boston University. Her residency was in the ophthalmology department at Mass Eye and Ear at Harvard. And this is a very distinguished group of class that she has there. Besides Lois, there are two others who were, I think, now chiefs of ophthalmology, as well as, I think, a dean of a whole medical school. So this is quite a crew she comes from. She also completed her fellowship in pediatric ophthalmology at Children's Hospital at Harvard. Her honors and awards are numerous. Briefly, she was recipient of the 2006 Bresser Prize in Vision Science, 2007 Alcon Research Institute Award for outstanding contributions to ophthalmology, and the 2008 Friedenwald Award, Association for Research in Vision and Ophthalmology for outstanding research in ophthalmology. She also received the 2008 ARVO Kless Best of the Best Award for the most outstanding lecture given at ARVO, our annual research meeting. She is a former member of the National Eye Institute Advisory Council and a member of the NEI Board of Scientific Counsel, or rather she's currently on the board right now. So indeed, Lois is a true clinician scientist who has an active practice in ophthalmology, in pediatric ophthalmology. She teaches medical students, residents, clinical fellows, and also graduate students. She's a terrific mentor in both the clinic and the lab. Her lab is focused mostly on research in retinal neovascularization, both basic mechanisms and treatment. Her work is truly translational. It pertains to neovascular diseases including diabetic retinopathy, AMD, and retinopathy prematurity. She's a pioneer in establishing the role of vascular endothelial growth factor in the pathogenesis of these diseases at both the basic level, and she has been involved in some of the clinical trials as well for these significant public health disease. In addition to being a major clinician scientist making seminal contributions, she is a wonderful wife, and she has two wonderful children, and she does all this with basically style and grace. So we present to you Lois Smith.
Thank you, Emily, for that very lovely introduction. It's a great honor to be here as a WALS lecturer. Today, I'm going to talk about understanding angiogenesis through the study of retinopathy of prematurity. In ophthalmology, pathologic neovascularization is the most common cause of blindness in all age groups. So in the elderly over 60, there are 15 million patients with AMD, and 20% of those will get wet or neovascular AMD. In the working age population, diabetic retinopathy is the most common cause of blindness, and about 7% of the population now has diabetes, and of course the numbers are increasing. And half of these patients will get diabetic retinopathy after 25 years. And in children born prematurely, retinopathy prematurity is the most common cause of blindness, or one of the most common causes. The way we treat retinopathy is by using laser photocoagulation to photocoagulate the retina. In this case of diabetes, all of these spots are areas where the retina has been destroyed, or in this case in ROP, all of this part of the retina has been destroyed, and that is to save the remaining retina. So clearly we want to understand a little bit better the pathophysiology so that we can treat medically and prevent the disease process. By looking at ROP, I think we can understand both diabetes, some aspects of AMD, and we can also understand vascular biology. We can look at vessel loss as well as vascular proliferation. And the reason to study ROP is that in theory, ROP is very simple, which is all we have to do is figure out what is the difference between what would happen in utero and what happens when babies are born prematurely. So we have a very easy comparison. we can look at normal vascular development, vessel loss, vessel repair, and pathologic neovessels. So let me just walk you through what happens in ROP. ROP is a two-phase disease, as is diabetic retinopathy. In the first phase of ROP, there is a cessation of vessel growth and loss of formed vessels. So with premature birth, the vessels that are provided, or sorry, the factors that are normally provided in utero are lost to the infant, and oxygen, even when not given supplementally, is above intrauterine levels. And this causes cessation of normal vascular development and, as I said, vaso-obliteration, leaving the peripheral retina avascular. So in phase 1, it's important to understand that the growth factors that are suppressed by oxygen are low. That is, I'm going to talk today about two of these, vascular endothelial growth factor and erythropoietin. And the factors that are normally provided by the mother are also low. And I'm going to talk about two groups, IGF-1 and the omega-3 polyunsaturated fatty acids. In the second phase, the opposite occurs in large measure. So the retina matures with increasing metabolic demand, and this leads to hypoxia. And at the junction between the vascular and avascular retina, you can get neovascular fronds that then cause tractional retinal detachment. The hypoxia can induce either normal repair or neovascularization. So in phase 2, unlike the first phase, the growth factors that are induced by hypoxia are now elevated. So instead of VEGF being low, as in phase 1, it's now high, and the same with erythropoietin. It was low in phase 1, high in phase 2. And at the same time, those that are provided by the mother are still low. So IGF-1, because the child has an immature liver and can't make it, is low. And omega-3 and 6 polyunsaturated fatty acids are provided by the mother, and they too are low unless they're given to the infant. We could study this process in the mouse because the normal mouse retinal vascular development between P0 and P8 mimics that of the premature child in the 4th trimester. So at birth, there are no retinal vessels, and they slowly spread out in the first layer so that at postnatal day 8, they've now reached the periphery. If at postnatal day 7 we expose these mice to 75% oxygen, we stop the progression of the retinal vessels, and those that are already formed disappear. So we can mimic the first phase of ROP. If we then bring the mouse back into room air, this retina is now hypoxic, and you get neovascular fronds that form at, again, the junction between the avascular and vascularized retina, and you get neovascularization at the disc with tortuous vessels, again mimicking aspects of diabetic retinopathy. We can use this model to look at things that cause vessel loss besides oxygen and intervention. So that if we look at postnatal day 8 and we look at the area of vaso-obliteration versus the total retina, we can look at vessel loss and intervention to inhibit vessel loss. If we look at postnatal day 17, we can look at the area of vaso-obliteration versus the total retinal area, which will tell us the regrowth of normal vessels. Or we can look at P17 and instead look at the neovascular fronds, which we can do in flat mount, and again determine the degree of neovascularization. And again, because this is quantifiable, we can then look at interventions for each of these parts of angiogenesis. I was interested in studying this disease process, looking at the risk factors for ROP, because it will tell us the risk factors will let us know which pathways are the most important in angiogenesis. We know that oxygen duration and oxygen level are major risk factors, as are low birth weight and short gestational age. So these correlate with oxygen-regulated factors as well as non-oxygen regulated factors normally provided by the mother in utero. So both of these are clearly extremely important in angiogenesis. I'm going to talk about oxygen-regulated growth factors first and briefly go through VEGF and then look at EPO. We've also looked at other HIF-regulated factors, IGF-BP3, and chemokines are also HIF regulated, but I won't discuss those today. So we first looked at VEGF some time ago, and we were interested because in the cancer field, VEGF had been associated with tumor vessels. And since we knew that hypoxia and hyperoxia were important factors in ROP, we exposed the mice to hyperoxia and then looked as neovascularization proceeded and found that VEGF was upregulated between 6 and 12 hours after the mice came back into room air. And this was shown as VEGF being elevated in the internuclear layer in the Mueller cells, as well as in the ganglion cell layer in the astrocytes. We also knew that VEGF was elevated in the vitreous of neovascular diseases such as diabetic retinopathy as well as ROP. We then used two different methods to inhibit VEGF by using intravitreal injections, first of antisense directed against VEGF, and then a VEGF receptor bound to IgG like an antibody, and showed that by injecting anti-VEGF compounds, we could inhibit neovascularization. So this is phase 2 of ROP, or phase 2 of diabetic retinopathy, or in AMD, the neovascular aspect of AMD. And this has been translated into treatment for AMD with intravitreal injections of antibodies against VEGF. And there are now clinical trials for ROP as well in the second phase. But again, in studying ROP, we were interested in the first phase as well, because we believed that if VEGF was important for neovascularization, it might also be important for normal vessel growth. And if it was suppressed by hyperoxia, then it could suppress normal vascular development. And indeed, we found that this was the case. We found VEGF anterior to the growing vessels. And when we subjected the mice to hyperoxia at postnatal day 7, this growing front of VEGF disappeared. So hyperoxia did suppress VEGF. And when we added VEGF, we injected VEGF into the vitreous of the mice, we could prevent vasoobliteration. So clearly, VEGF is required for normal vessel survival, and it's clearly an important aspect of the first phase of ROP, and means that we ought to be rather careful in inhibiting VEGF in both AMD and diabetic retinopathy as well, so that we don't, in fact, suppress normal vascular growth. In the ROP model, we were also interested to know whether or not VEGF was important for neuronal development. We found that VEGF receptor 1 was localized to blood vessels, but VEGF receptor 2 was actually localized to neuronal retina. And as you can see here, these are endothelial cell markers, but there's an exact negative at this point. So VEGF receptor 2 is only in the neural retina and not in the vasculature. We then did an experiment knowing that at postnatal day 5, there's incomplete vascular development in the retina. So in this area, we have normal neuronal tissue that is avascular. And if we gave VEGF receptors inhibitors, Sugen 5416, we saw a decrease in the development of the neuronal retina that was independent of the vascular development. So again, this indicates that we're going to have to be careful in inhibiting VEGF so that we don't inhibit neuronal survival as well. So I think by looking at ROP and knowing that this is a two-phase process, we can bring to the attention of clinicians that the timing and the degree of VEGF suppression is critical. And the other thing that we could understand from this is because we did not get 100% suppression of neovascularization, that VEGF is not the only factor controlling angiogenesis. So I'm going to talk next about another HIF-regulated factor, erythropoietin. It's a hormone produced in the kidney, which promotes erythrocyte formation in bone marrow, and it's widely used for treating anemia, including patients with ROP and diabetic patients, as well as patients with cancer. So we were concerned about the effect EPO might have on vascular stability in retinopathy because there were two publications that suggested that cancer patients who had high doses of EPO had an increased morbidity and mortality due to probably increased cancer growth. And another paper suggested that patients who had high doses of EPO also had increased vascular events such as stroke and myocardial infarctions. So we first looked at retinal EPO production during the production of retinopathy in the oxygen-induced retinopathy model. And what we found was that similar to VEGF, in the retina, EPO is markedly suppressed by about 30-fold when the animals are exposed to hyperoxia, and it increases when they come back into room air when the retina is hypoxic, again about 30-fold. So we wondered whether or not by replacing EPO that was suppressed by hyperoxia, we might be able to prevent vascular loss and prevent neovascularization. And in fact, we found that that was exactly the case. In a dose-responsive manner, we found that giving EPO early, during this early phase, prevented vascular loss. And by preventing vascular loss and then looking at postnatal day 17 when there was neovascularization, we could inhibit the production of neovascularization. So again, treating early by preventing vessel loss prevented the pathologic production of vessels. In a paper in the New England Journal of Medicine in 2005, Watanabe and co-workers found that EPO was elevated in the vitreous of patients with proliferative diabetic retinopathy. We then used suppression of EPO in the second phase of neovascularization in the OIR model with EPO siRNA, and we found that by treating late, again in the phase where EPO is elevated with a hypoxic retina, we could get suppression of neovascularization. We found that this EPO protective effect was independent of VEGF. There were no changes with EPO treatment in VEGF or VEGF receptors or in HIF. And we found that the mechanism of treatment early was that, first of all, we found EPO receptor throughout the retina, so in neural retina as well as in the vascular endothelial cells. We did this by using laser capture of different elements of the retina and then using real-time RT-PCR. And we found that it protected the retinal neurons from apoptosis through inhibition of caspase activity, and it protected through recruitment of endothelial progenitor cells. So we saw a 50% increase in CD34 positive cells that caused reformation of vessels, and it also protected through recruitment of macrophages, which also are known to promote normal vascularization. So EPO has an effect that is as great as VEGF and is neuroprotective when we bring it back to normal levels. There was an interesting paper in ILVS by a group from China that showed in STZ diabetic rats, after the onset of diabetes, there was a breakdown in the blood retinal barrier and apoptosis of the neural retina, and increased EPO receptor in the neural retina at 4 to 8 weeks after the onset of diabetes. With a single injection of EPO at the onset of diabetes, all of these changes were prevented in part. So that there's an EPO receptor survival mechanism of the retinal neurons that responds to the early insults of diabetes with appropriate restoration of EPO levels to normal. So again, I want to emphasize that EPO regulation is independent of VEGF, and the inhibition is additive to inhibition of VEGF in phase 2, but that EPO is also important for the first phase, and I think we need to think in angiogenesis terms about normalization of both VEGF and EPO. I'm now going to switch gears a little bit and talk about two factors that will help us understand angiogenesis a little bit better by referring to what happens in the third trimester. So when babies are born prematurely, they lose the third trimester in utero, and they lose all of the factors that would normally be provided by the mother. So I'm going to talk about growth hormone and IGF-1, and then omega polyunsaturated fatty acids. So we knew that, I mentioned earlier, that prematurity per se is the greatest risk factor for ROP. So that we know that growth hormone and IGF-1 are bound to be very important in this process. And growth hormone had been implicated in proliferative diabetic retinopathy. In the 1950s, there was an ophthalmologist who noted that a patient who had proliferative diabetic retinopathy and then had a pituitary infarct at the time of birth, of giving birth to a child, had resolution of the proliferative diabetic retinopathy. And based on that observation, ophthalmologists and neurosurgeons began to do pituitary ablation to treat patients with proliferative retinopathy. This was prior to laser photocoagulation. And when laser photocoagulation came along, then this was no longer the appropriate treatment. However, because it had been shown to be effective, I wanted to look at growth hormone as part of this, part of the pathways that might in fact alter the incidence of retinopathy. And we looked first at mice with inhibition of growth hormone and found that in the OIR model, when growth hormone was inhibited, in fact, there was a significant reduction in phase 2 in proliferative retinopathy. And we showed that this was due to IGF-1. We showed that by inhibiting the IGF receptor with an antagonist, we could have a dose-responsive inhibition of retinopathy. So this showed that in phase 2, IGF-1 through growth hormone was very important. But we really wanted to look at the first phase of ROP because in the first trimester, fetal IGF-1 levels rise very rapidly in utero, and they fall precipitously when a child is born prematurely. Therefore, low IGF-1 levels in the first phase might in fact be important in the development of retinopathy. So we looked in IGF-1 knockout mice and found in fact that with low IGF-1 we had a significant inhibition of normal vascular development. So we hypothesized that IGF-1 deficiency precipitates ROP, because the suppression of vessels in phase 1 creates hypoxia, and the hypoxia determines the degree of neovascularization. So we hypothesized that those infants with ROP have low levels of IGF-1. So we did a clinical study with Ann Hellstrom in Sweden and did a prospective longitudinal study of 84 infants who were born less than 32 weeks gestational age. And we took serum IGF-1 measurements and then did routine ROP evaluations. And what we found confirmed that, in fact, low IGF-1 is associated with worse ROP. So these are the 95% confidence intervals for in utero IGF-1 levels. And this is the mean. What we found is those infants who had the worst ROP had the lowest IGF-1 levels and never quite made it even into the 95% confidence interval here in utero levels. And those patients, the infants who had no ROP, had in fact the highest levels. So again, this was a strong association showing that perhaps low IGF-1 levels can precipitate retinopathy by not allowing normal vascular growth and development and survival. We wanted to understand the mechanism by which this happened, and we hypothesized that IGF-1 probably controlled VEGF signaling. So what we looked at is in cell culture, we looked to see whether or not abnormal levels of IGF-1 signaling altered the signaling through MAP kinase or through AKT, which are the growth and survival mechanisms of endothelial cells. And what we found was that with low levels of IGF-1 signaling in fact, we got much less VEGF signaling through MAP kinase. And with low levels, which are equivalent to what we saw in the babies with ROP at 10 nanograms per milliliter, we found that, again, we did not get optimal signaling through AKT. So, in fact, IGF-1 is required for VEGF to maximally induce vasoproliferation and survival, and low IGF-1 will prevent VEGF-induced angiogenesis and will foster the loss of existing vessels. I'm going to go to the last part of the talk before trying to pull all of these aspects together to understand angiogenesis a little bit better. So we look next at the omega fatty acids in terms of ROP and other retinopathies. In the third trimester, there's a massive transfer of omega fatty acids from the mother to the fetus, which again is lost to the infant who's born prematurely. And in total parenteral nutrition that's given to premature infants, omega-3 fatty acids are not included in the TPN solution, only omega-6s. We also know that omega-3s are often found in low levels in adults, and so this might have implications for diabetes and AMD. And this work was done with John Paul Sangiovanni and Emily Chu and Deborah Carper here at the National Eye Institute. In terms of dietary percentages of energy from N3 long-chain fatty acids by country, this work was done by one of the members of our audience here. And it shows that in the US, we're somewhere in the middle, but nowhere near as good as Japan and Iceland, although not as bad as some of the middle European countries like Bulgaria and Romania. The tissue status of polyunsaturated fatty acids depends upon dietary intake. It's a major structural lipid found in the retina, and we thought that these nutrients would be reasonable targets for, as I said, diabetic retinopathy, ROP, and AMD intervention. And Emily and co-workers at NEI had already shown in the ARIDS-1 study that there was a correlation between fish intake and the development of AMD. It turns out that the retina has the highest levels next to sperm and cerebral cortex of the omega-3 fatty acids. So again, a little change in diet we thought might have a huge change in the retina itself. And another really interesting study suggested that this was a very safe kind of intervention. Mortality from all causes associated with dietary intake of omega-3 shows that in countries with the highest intake, they have the lowest mortality compared to those with the lowest intake. So again, it doesn't take into account suicide or motor vehicle accidents, but it certainly is very intriguing. So we wanted to find out what effect these molecules would have on retinopathy, and to do this, we again studied it in the ROP model. I'm just going to take you through a little bit some of the pro-inflammatory and anti-inflammatory byproducts of the polyunsaturated fatty acids. So both omega-6 and omega-3 PUFAs go through phospholipase A2, and arachidonic acid and omega-6 goes through COX-LOX and produces pro-inflammatory heats. DHA and EPA go through the same enzyme systems, but produce resolvins and neuroprotectins, which are anti-inflammatory. To study this, we did an experimental design that took advantage of both a genetic approach as well as a dietary approach. So in the oxygen-induced retinopathy model, we first took transgenic mice, FAT1 mice, that expressed the gene from C. elegans, which allows them to convert omega-6 PUFAs to omega-3 PUFAs, resulting in a high omega-3 to omega-6 ratio. We also took a dietary approach where we took C57 block 6s and put them on either a high but physiologically normal diet or a high but physiologically normal omega-6 diet. The diets were otherwise matched and isocaloric. The mothers were given the diet following birth, and we found that the lipid content of the milk reflected the lipid profile of the mother's diet. We found that all of the principal omega-3s increased with both the omega-3 PUFA-enriched diet and in the FAT1 gene, with the FAT1 gene expression in the pup retinas. And the omega-6s decreased in the omega-3 feeds and in the FAT1 group. So the important take-home lesson from this was that with a 2% change in diet, that is substituting 2% of the omega-3s for the same 2% of arachidonic acid, gave us a twofold increase in the total omega-3 to omega-6 ratio in the retina. So a very small change in diet gave an enormous change in the retinal composition. We then looked to see how much pathologic neovascularization there was at P17 with these diets or with the FAT1 mice. And we saw there was approximately a 50% inhibition of neovascularization with either the diet or with FAT1 expression. And it's important to keep in mind that this is comparable to the results that we got with VEGF inhibition. So this is a very important pathway in angiogenesis and in retinopathy. We also found that the omega-3 PUFAs were associated with more vascularized retina at P17. So we looked at the area of vaso-obliteration at P17. So this can occur only by the retina revascularizing in a normal way. So we saw, again, about a twofold difference in revascularization with the omega-3 versus the omega-6 feed. And we knew, as I said, that this was secondary to regrowth because when we examined these at P12, when they're still in just after hyperoxia, we see at P13, P15, and P17 with FAT1 versus wild type an increase in the vascular growth. And the same thing with the feed. So again, this is through normal vascular development. We then looked to see whether or not the bioactive metabolites of the omega-3 PUFAs were protective. So again, EPA and DHA go through these pathways to form, EPA forms resolvin E2 and resolvin E1, and DHA forms the D-series resolvins as well as neuroprotectin D1. So we took these 4 molecules and again injected them into the mice to see whether or not the bioactive metabolites were also protective. And we found that all of them were about equally protective in preventing both vaso-obliteration and neovascularization. In cell culture, DHA, EPA, and resolvins and neuroprotectins block the production of pro-inflammatory cytokines, in particular TNF-alpha, through regulation of NF-kappa B. So we asked if TNF-alpha was involved in omega-3 PUFA suppression of retinopathy. Whoops. And we found that the omega-6 diet had a much higher production of TNF-alpha message than the omega-3 diet at P8 and P14, and this was also reflected in the protein level. When we used etanercept, which is a soluble TNF-alpha receptor, we found that we got suppression in both the omega-6 and omega-3 diet group, showing that TNF-alpha, in fact, further suppressed retinopathy. And in TNF-alpha knockout mice, we got no further suppression. So TNF-alpha is a very important player in angiogenesis, and omega-3 PUFAs tap into this by partly suppressing TNF-alpha as part of their mechanism of action. In P17 retinas, we immunolabeled vascular endothelial cells, macrophages, ChemR23, which is a receptor for resolvin, and TNF-alpha and activated NF-kappa B. And what we found was that TNF-alpha was closely associated with a subset of macrophages that were closely associated with blood vessels, but not all macrophages. And the resolvin E1 receptor, the ChemR23, was found only on that same subset of macrophages associated with blood vessels. And NF-kappa B activity, which is suppressed in the omega-3 PUFA mice, was localized to the same macrophages as the TNF-alpha. So these resident macrophages are clearly an important part of this whole mechanism. So again, I just want to emphasize what the important parts that we found is that a moderate change in dietary intake of omega-3 fatty acids, 2% change in diet, resulted in a twofold change in the ratio of omega-3 to omega-6 PUFAs. And mice on a physiologic but normal omega-3 diet versus a physiologic but normal omega-6 diet, comparable probably to a Japanese diet versus a Western diet, had significantly improved recovery from vessel loss and suppression of retinal neovascularization. So we believe that increasing omega-3 PUFA intake in adults on a Western diet or in premature infants will decrease the risk of retinopathy very significantly. So I'm just going to pull this all together because there's a lot there and it gets complicated. So this is kind of a cartoon. If the retinal composition has more arachidonic acid or omega-6, when the turnover occurs in the retina, which it does frequently, the arachidonic acid will go through COX and LOX to form the 2 series prostaglandins and the 5 and 12 and 15 heats. These are pro-inflammatory. They cause activation of NF-kappa B and TNF-alpha production. If, however, the composition of the retina is different so that there's a higher level of DHA and EPA, they go through the same pathways, through COX and LOX, but instead produce the 3 series prostaglandins and neuroprotectin D1 and resolvin E1 and resolvin D1. These are anti-inflammatory and they cause inhibition of NF-kappa B and less TNF-alpha production. So I'm just going to try to integrate all of this and put it together. So in terms of retinopathy of prematurity, when a child is still in utero, there's normal vessel growth. There's a wave of VEGF that is in front of the growing vessels. IGF-1 levels are normal, produced by the mother. EPO levels are normal, there's no hypoxia, hyperoxia. And omega-3 PUFA levels are normal, produced, again, given by the mother. After premature birth, however, IGF-1 levels plummet, VEGF levels plummet because even room air is relatively hyperoxic. The VEGF in front of the growing vessels disappears, and IGF-1 levels are low enough such that what VEGF does exist cannot signal through AKT and through MAP kinase. And omega-3 PUFA levels are very low, again, because the child is not given any supplements with omega-3 fatty acids. So blood vessel growth stops. We can either intervene at this point, and we can raise this back to normal. We can increase VEGF to normal by at least changing the oxygen tension outside or inside by lowering oxygen levels given to the child. EPO levels, again, will be affected by the oxygen that we give to the child. And we could supplement with omega-3 PUFAs, which will bring us back to normal vascular development. However, if we wait until later to the second phase of retinopathy, where where VEGF levels are very high, because with metabolic demand, the retina then becomes hypoxic, and we get neovascular tufts here. So VEGF is high, EPO is very high, omega-3 is still low. So what we can do at this point is we can suppress VEGF and suppress neovascularization. We can suppress EPO and suppress neovascularization. If we raise IGF-1 too high, we're going to increase the amount of neovascularization. So at this point, we then suppress these factors to bring it back to normal. And what we are trying to do is increase our understanding of how we can normalize at this point rather than at this point. Diabetic progression is similar, although less is understood. So again, in a normal eye, there are normal insulin levels, normal IGF-1 levels, normal glucose levels, normal EPO, normal VEGF, normal lipid metabolism. In a diabetic patient, we have different insulin levels. Insulin is given on an intermittent basis, so instead of having an even amount, we have increased or decreased amounts of insulin. IGF-1 levels, although they are often normal in diabetes, by giving IGF-1, you can prevent some of the changes that occur. So IGF signaling is probably abnormal. Glucose is clearly abnormal, either high or sometimes low with tight control, and lipid metabolism is normal. We don't know enough about this phase to bring this back, although I think this is where we ought to try to bring the diabetic eye again back into the normal metabolic pathways. We do know how to treat at this point. We know that when VEGF levels are very high in proliferative diabetic retinopathy, that if we give an anti-VEGF treatment, we can suppress neovascularization. But interestingly, certainly with AMD, the treatment can be as frequent as every 4 to 6 weeks, where anti-VEGF injections are given intravitreally. So again, there's still a stimulus to produce blood vessels because of hypoxia, and we would be better off trying to treat at this early phase. So our general conclusions are that the medical treatment options for ROP are we can replace IGF-1 and IGF-BP3, and in fact, we are now in a phase 2 trial about to begin phase 3 in Sweden by replacing IGF-1 to normal in utero levels in premature infants to see whether or not we can not only prevent proliferative retinopathy, but also prevent some of the neuronal damage that occurs in the brain in these infants. Many children with ROP also have profound neurologic deficits. We also would like to replace omega-3 PUFAs, and we have a trial in the planning phase in ROP. Our difficulty is that we don't have FDA approval for using Omegaven, which is the TPN which contains omega-3 rather than just omega-6s. And we are also in phase 2 of a trial for ROP suppressing VEGF in the second phase of retinopathy. But our findings in ROP, I think, will translate to diabetic retinopathy and to AMD. So VEGF suppression in the neovascular phase is successful in AMD and may translate to diabetic retinopathy, although the clinical trials are still in progress in diabetic retinopathy with VEGF suppression. Omega-3 PUFAs are a very inexpensive possible treatment, however, to prevent possibly diabetic retinopathy and AMD. And again, John Paul Sangiovanni and Emily Chu are, and many other co-workers are in the midst of the ARIDS-2 trial to see whether or not supplements, in fact, will prevent the development of late-stage AMD. And inhibition of EPO is as effective as inhibition of VEGF in the second phase of ROP, and it may be an effective complement to anti-VEGF therapy when, in fact, in patients with AMD or other retinopathies do not respond to anti-VEGF treatment. And we can also consider EPO treatment for anemia, which could be timed. So right now, EPO is given to patients who are anemic, but without regard to whether or not they're in the proliferative phase or whether or not they're in the early phase. And early treatment may in fact help prevent retinopathy, whereas late treatment has the possibility of exacerbating retinopathy. I want to thank the people in my laboratory who have done this work. Kip Connor did much of the omega-3 fatty acid work, and Jing Chen did much of the EPO work. And these are some very talented other postdocs who've also been involved, as well as pre-doctoral students. I love to hire students from Bowdoin College and Harvard and Williams who want to go on to medical school. So Kiernan is going to Penn in the fall. This is Chris, who started Harvard Medical School this fall. And Nate and Bobby are in the application process for medical school. So I'm very proud of them. And I also particularly want to thank the people at NEI, John Paul Sangiovanni, who was intimately involved with the omega-3 work, and Emily Chu and Deborah Carper, and also Paul Sieving, who is our institute director, who has been very supportive of this work, as well as Grace Shen, who is my program officer. And I really appreciate the funding from the National Eye Institute and the National Institute of Health to do this work. Thank you.
Hi. Is there any evidence as to whether or not the absolute level of omega-3s or the omega-3 to omega-6 ratio is the critical factor?
We don't know. We really don't have that information. I hope that perhaps more will come out of the ARIDS-2 study to give us more information about that. But I think Emily's looking at specific doses of the omega-3 supplements. But I'm not even sure if you're not looking at the ratios, are you? No.
So, very nice talk. So, do you think that common signaling pathways are induced in all three diseases before angiogenesis begins? I mean, the initiators in all three diseases are going to be very, very different. But do they lead to something similar?
I think so, and I think it's probably apparent because of the response of wet AMD to anti-VEGF therapy. So clearly the VEGF path is common to all three, but I'm sure some of the other pathways are as well. I think that the IGF-1 pathway may well be involved as well. It hasn't been as studied as thoroughly as I think we would like in diabetic retinopathy. I mean, IGF-1 is really important. There was a study that was done probably 4 or 5 years ago through a private company where they looked at using IGF-1 rather than insulin. And this company that will remain unnamed used very, very high doses of IGF-1 to treat patients with diabetes. And they found, at least by rumor, that very high doses caused neovascularization of the disc. And so that was all stopped. But there are other anecdotal reports that suggest that if you treat with IGF-1 in diabetes, you decrease the need for insulin, and you can use IGF-1 much like you use insulin, but in a much more controlled way. The diabetes is much less brittle with IGF-1 than it is with insulin. So I think there's a lot of work to be done with IGF-1 and diabetes, but I think that's another pathway that is in common. And we just really don't know what it is in age-related macular degeneration. IGF-1 levels fall with age, but we really don't know what that correlation is. And I think the omega-3 fatty acid pathway is also in common, at least at the end stage. And I think there will be aspects of the phase 1 that will also be in common. Clearly, as you said, the initiators will be somewhat different, particularly with AMD. I think that's a different entity associated with age. But for diabetic retinopathy and ROP, even the initiators, I think, are going to be similar.
Well, Lois, nice talk. Thanks very much for all the insight into the developing retina, but I'm just worried that you have a very immature organism, and there are other systems, the hematopoietic system, the pulmonary system, that are also very immature. Are there any confounding effects of some of the treatments that you've been looking at on some of these other organ systems?
You mean when we're thinking about treating kids with ROP?
Yeah.
Yes, I think there certainly can be. And in the study with inhibition of retinopathy with anti-VEGF therapy, there is a great deal of attention paid to the other systems. So in this trial, the trial really started because it's being used ad hoc by many, many ophthalmologists over the world. And we wanted to make sure that we had something that was controlled, and we had doses that were examined in a controlled way. So given that, yes, there's real concern about high levels of anti-VEGF therapy in a neonate with a developing lung, developing brain. However, I think a single injection of IGF-1, which is all it takes in most cases, is probably relatively safe because the amount of VEGF in the vitreous is quite high, so it's bound to VEGF and then it gets cleared rather slowly. So it appears as though it's probably going to be okay. However, having said that, doing neurologic evaluation on these kids is difficult. Many of these children have profound neurologic problems, and I think any assessment in talking to the neonatologist is going to be very difficult because of the background neurologic deficits that they have anyway. But yes, it's a really important issue. I think supplementing IGF-1 to normal levels can really cause no harm. All we're doing is providing the levels that would normally be provided in utero. And similarly, if we could bring VEGF levels up to what was normally present in utero, then again we would be approaching this from a less potentially damaging position. So that's why I was saying that we're really interested in attacking phase 1 rather than phase 2.
Thank you, Lois, very much for coming. It was a terrific lecture, and thank you very much again.